Good evening, everyone. And at the outset, let me thank the organizing secretary for this opportunity and thanking Dr. Pankaj Shah sir for the kind introduction, sir. And my topic for today is EGFR and ALK mutation in lung cancer and outcome in Indian patients. And I'll try to show that what is happening in Indian context. Maybe not as exciting as some of the lectures we heard, but hopefully sobering and reassuring. Starting with the molecular profiling, this is the data from Indian context, adenocarcinoma. This is the kind of mutations what we get, maybe similar, but different proportions. This is the squamous cell data, and this is a bit striking, and it is important because it helps in our clinic. And what we did observe that good number of our patients, they do have EGFR activating mutations where we can work upon it. And it will be good to see that in NCCN guideline also, it is getting reflected that there is an acknowledgement that in squamous cell carcinoma, you do have mutations which can be targeted, including EGFR mutations. Coming to EGFR mutation per se, this is the incidence rate with around 1,000 odd patients, what we had, that was around 23%. Looks like it has stayed true. And this is in 9,000 odd sample, similar number of patients getting EGFR mutation in our population. Coming to the outcome, one of our first study, which we compared the targeted therapy to chemotherapy, and what we found that in our population also, this is the updated data. The disease control is better with targeted therapy, that is gefitinib, as compared to pemetrexed carboplatinum. And this is the updated overall survival data, suggesting that overall survival is similar in both arms, and that's primarily because there's a whole lot of crossover which happens from chemotherapy to targeted therapy and vice versa. We also did analyze data for squamous cell carcinoma patient with EGFR mutation, and what I can conclude, the most important factor in these patients remains they are able to take TKI or not. It is important that in squamous cell carcinoma patient also, if you have EGFR mutation positivity, then one needs to give TKI to these patients to improve the outcome. We do encounter many uncommon mutations. This number is going to increase. These are the initial experience of the uncommon mutations in EGFR mutation positive patients, and what we can say that they are not all the same, and the outcome varies from the median survival of around 2 months to 22 months. So we will be able to decipher this as the time goes by for these uncommon mutations, and we will have more and more of them being sensitive where we can use the TKI, and many more of them which are not so sensitive, which we will require some other treatment or not to give TKI. Can we get better? And this was our own work, which we combined gefitinib plus chemotherapy as compared to gefitinib. And this was the trial design where these EGFR mutation positive patients with palliative intent treatment were randomized between TKI to TKI plus chemotherapy. These were 350 odd patients which were randomized, which suggested that if you combine it, then you do have a better control of disease and also better survival. And right now we do also have the updated data, and what we can see that in our population also you have significant proportion of patients who do survive beyond 4 years, 5 years and beyond, and the survival advantage to this combination remains. The median survival improves from 19 months to 28 months in these patients, highlighting that this happened during the time where we do had a COVID issues where the chemotherapy administration became a challenge in these patients, but it appears that adding the chemotherapy in these patients, the advantage for adding the life to the patient remains. We see the options of the first-line treatment in these patients and leaving the initial, the TKI, which we think they may be relatively inferior in controlling the disease. In the other 5 options, the option of combining chemotherapy to TKI is most affording to our population, especially in the situation where if we want that these patients have better survival as compared to giving only older TKIs. Coming to ALK positive patients, this is the ALK positivity in our population. The recent data with 5,000 plus patients, it appears the positivity rate is around 10%, and it appears that it remains sustained, suggesting that we may have a higher positivity as compared to what we have seen in the Western world. Coming to outcome of these patients of ALK positive patients in our population, primarily where we use crizotinib and ceritinib. These were the initial publication, and now this data is for 400 plus patients, that is 441 exactly. We were able to give the first line TKI in 65.8% of the patients, and overall 80% of the patients received TKI sometime during their treatment, and highlighting the issues why we were not able to take it, and also highlighting that if you put effort, then if you involve the NGOs, then you are able to provide treatment to majority of the patients in this setting with some one of the TKIs. Coming to outcome of these patients, if we take the progression-free survival, this was 17 months with the first generation TKI, what was given to these patients, that is crizotinib and ceritinib, as compared to the patient where we were not able to give TKI in the first line setting. This is, remember, out of this 149 patients, there were patients who received TKI in second line setting. Coming to overall survival, in overall group of these patients, that was around 30 months odd. As we had a group of patients who never received TKI, because I suggested that we tried our best to get TKI for these patients, but that also gave us a chance to compare these patients who received TKI versus who didn't receive TKI, and it appears giving TKI adds life to the patient, and the median survival was around 32.8 months as compared to around 12 months in these patients. We also analyzed the data for poor performance status patients because we had a significant proportion of patients who were poor performance status, and we tried to analyze this poor performance status patient who took TKI and who didn't take TKI, and it appears in this population also giving TKI adds life to the patient. As we had some decent number, so we could decipher between the PS performance status 2 patient as compared to performance status 3 and 4, and it appears that performance status 2 patients do better than performance status 3 and 4, and these performance status 3 and 4 patients, where we expect the median survival of around 3 to 4 months, we could get the median survival of around 8.6 months if this TKI is given. And you do have some proportion of patients who survive beyond 2 years in this population. Overall survival, as far as the brain mets is concerned, it appears that giving them first and second generation TKI, where majority of the patient did receive radiotherapy, there is no difference in the outcome. Coming to long-term outcome, we tried to analyze the data for the patients who had minimum 4-year follow-up after their last treatment, which has been given when the treatment was started to them, and it appears that the 5-year survival in these patients is around 40%, which is encouraging. We did have some patients who received lorlatinib. This was the initial data which we did analyze, and it appears in this setting. In our population, the progression-free survival is around 16 months, and with median OS of around 21 months in this population. We had a chance of, because having this mutation profiling, having coexistence of mutations like EGFR and KRAS, and it appears in this situation giving TKI is meaningful, but I'm not sure what will happen once we have KRAS inhibitor available in this population. We also had the data for having EGFR and ALK mutation positive patients, which we had around 24 of them. This were the population which were positive by IHC in all, and one positive by FISH for ALK, and all the patients were positive for EGFR mutation by RT-PCR. And what we see here, that one of the most important factor remains that were we able to expose them to TKI or not, and most important, looks like exposure to ALK inhibitor becomes most important factor, suggesting that exposure to TKI is important, and it appears the patient who are exposed to ALK TKI, they do far better. I can't say conclusively, but looks we need to expose these patients to both TKI. Is giving concurrent TKI useful? I can't say for sure, not conclusively. We did have a few patients where we have given it, but can't say for sure with the data which is available that the giving concurrent is useful as far as the outcome is concerned. But it is true that it is safe to give them concurrently. So in conclusion, there have been significant development in management of lung cancer for EGFR and ALK mutation. Targeted therapy has significantly improved the outcome. It is important that we develop the diagnostic tests and also the treatment protocol at local level if you want to have a better outcome of these patients. And not to forget, the tobacco remains the most important preventable cause, and we need to focus on that. These are the acknowledgements for my students and my colleague working with us in the lab, and my colleague who works. What we have seen the lab data primarily from is from Dr. Amit Dutt and Dr. Anuradha Chaugle, and apart from that, Dr. Vijay Patil, Dr. Amit Joshi, Dr. Vanita Narona, and Dr. Nandini, who is my colleagues who worked on it. This is the lab people who worked, and these are my seniors and my collaborator and the family. Thank you so much.